Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM, a cardiologist from Houston, Texas. This is Cardiology Seminars. The focus today is going to be right bundle branch block EKG findings and clinical significance. On our YouTube channel, we have more than 160 lectures covering various topics in cardiology, and feel free to watch any one of those videos which are free. So let us jump right into the topic of the right bundle branch block. Before we get into the right bundle branch block EKG findings, a brief summary of the electrical system of the heart. As you can see, we have the sinus node here. Then we have the interatrial connections which connect the sinus node to the AV node. From the AV node, we get the bundle of His, which divides into the right bundle branch block, right bundle and the left bundle. The right bundle has a single trunk which traverses through the septum, and for the most part, its Purkinje system supplies the right ventricle, whereas the left bundle supplies the left ventricle and the septum also. Since this is supplying the right ventricle, the changes we're going to see will be in leads V1, V2, V3, and of course AVR. So let us switch gears and look at what are the classical changes that we see in patients with right bundle branch block. If you look at V1, the classic changes we are going to see will be an RS R prime with the downsloping ST segment and an inverted T wave. Usually you have a tiny R wave, then a deep S wave, flat ST segment, and an inverted T wave. However, in the presence of a right bundle branch block, we have this classical rabbit ear pattern, which is the small R, small s, and a big R pattern with the prolongation of the QRS interval, downsloping ST segment, and an inverted T wave. And these STT changes are known as the discordant changes related to the right bundle branch block, or for that matter, left bundle branch block. Another characteristic feature we're going to see with the right bundle branch block is the slurring of the S wave in V5, and as a matter of fact, this slurring of the S wave is seen in many leads, which is one of the hallmarks of the right bundle branch block. The QRS duration could be anywhere from 110 to more than 120 milliseconds. If the QRS duration is greater than 120 milliseconds, it is considered a complete right bundle branch block, whereas if the QRS duration is less than 120 and greater than 110, it is considered incomplete right bundle branch block. Okay, here is an example of an electrocardiogram. First of all, we need to establish the rhythm. Here we see a P wave, P wave, P wave, P wave. So we have a sinus rhythm. We have the classic rabbit ear pattern of a small r, small s, and large R prime. So this is a classic example of a right bundle branch block, which is reflected in lead V1 predominantly. We may see a similar pattern in V2, but most obviously we see this pattern in V1 and to some degree in AVR. The second point I would like to bring to your attention is this slurred S wave, which is seen in multiple leads. We have seen here, we have seen in ABL, and even in the lateral leads we can see the upstroke of the R wave is sharp, very quick, whereas the S wave is slurred. And I also talked about the downsloping ST segment and the T wave inversion, which are the discordant changes related to the bundle branch block. The bundle branch block pattern can vary in many different ways. Usually the right bundle branch block, it does not signify significant underlying pathology as compared to the left bundle branch block, but nonetheless the presence of a right bundle branch block, which was not there before, in a patient with an anterior myocardial infarction may suggest a worse prognosis compared to a patient with an anterior infarct who does not have a right bundle branch block. So So that's one clinical point. There is another point here which we need to pay attention. Here is the axis is greater than minus 60 degrees. So we have a left axis deviation. We since have tiny airways in the inferior lids. So this is left anterior hemiblocks. So in a sense, we have not only right bundle branch block, but we also have a left anterior hemiblock. Putting these two together, now we have a bifascicular block. To that, some people say if you add a first degree AV block with prolongation of the PR interval, it may signify trifascicular block. Why are bifascicular and trifascicular blocks important? When we use drugs like beta blockers, we need to be cautious because these patients may progress to complete heart block. The main features of the right bundle branch block, to summarize, includes the small r, small s, large r prime in V1 with a slurred S wave, which I talked about, 1 AVL V5 to V6. QRS duration of greater than 120 milliseconds, and STT deflection in the opposite direction of the main R wave. No alteration in the electrical axis. The previous EKG we saw, we had a left anterior hemiblock, left axis deviation, but that is independent of isolated right bundle branch block. But if we see those, there may be disease involving not only the right bundle, but also the left anterior fascicle. Sometimes we can see right bundle branch block, which is rate dependent. If the heart rate is like 80, you don't see the right bundle branch block, but when the heart rate goes to 110, 120, 130, you may see the right bundle branch block, and that is called the rate dependent right bundle branch block, because the right bundle is thinner than the left bundle, so the right bundle is more prone to get fatigued during rapid heartbeats. As a result, we may see rate dependent right bundle branch block. As I already mentioned to you, if the QRS duration is between 110 and 120 milliseconds, it is called the incomplete right bundle branch block. Here are various patterns of right bundle branch block we may see. I'll just pause here and you can look at these. There can be variations in the R wave, the S wave, and the R prime, and their depths can vary depending upon various situations. So these are all variations of the right bundle branch blocks. If you're looking at an electrocardiogram, you're not going to see the classic M pattern, rapid ear, small ear, big ear pattern all the time. So you have to keep in mind, here you have a QR complex, but still the increased duration with the discordant STD changes. This is also an example of right bundle branch block. So keep these things in mind as you look at them. And there's one more condition I would like to talk before I conclude, and that is the Brugada Syndrome, characterized by a small r, a deep S, and another tiny r prime with seen in the anterior leads, which mimics right bundle branch block. The interesting thing is the Brugada EKG right leads show an ST elevation with an inverted T wave, and it is associated with ventricular arrhythmias. The QRS duration in Brugada is between 100 and 120 milliseconds. It is not quite close to the complete right bundle branch block where we see the QRS duration greater than 120 milliseconds, and it may also mimic anterior myocardial infarction. Now here is an example of a Brugada syndrome where we have the small or deep S and another tiny R wave which is bigger than the first one. Then we have the downsloping ST segment with ST elevation from the baseline with an inverted T wave. And when we see this, we always need to think about Brugada syndrome as for symptoms of palpitations, dizziness, or blackout, because these patients are prone for ventricular arrhythmias. This is characteristic of Brugada syndrome. Keep that in mind because you may be confusing this to a classic right bundle branch block. Well, ladies and gentlemen, I have created a cardiology rotation manual. If you are rotating through cardiology service, if you're a first year fellow or a medical student or a resident and you're rotating through cardiology service, where do you start? This is where you start with the cardiology rotation manual. And this is about more than 125 pages of collection of all the good information about what kind of history you need to ask and how you navigate through the challenges of managing a patient in cardiology floors. You can get a free copy of this by sending us an email to drniknikam@gmail.com. This has been a presentation of the cardiology seminars, and please do watch more than 160 lectures we have on cardiology on our YouTube channel. This has been a presentation of Triple N Media. I am Dr. NIK NIKAM, a cardiologist from Houston, Texas. And please do subscribe to our YouTube channel, and I will see you next time.